morning, everybody. Thank you for joining us today. I'm Lisa Levine with Dementia Alliance, and I am thrilled to have our guest speaker today, Latoya Galberth from Galberth Health. Thank you so much, Latoya, for being with us today and sharing your expertise on a very important topic. We welcome everyone. We know there will be a few more people joining us along the way. I did want to remind you that this is being recorded and it will be available on our Dementia Alliance of North Carolina YouTube channel once it's ready to go. We wanted to thank our sponsors this morning, ESI and Aware Senior Care, who have made this possible. And wanted to just do a really quick, brief introduction of our speaker. Latoya has worked with Dementia Alliance for many years. She's a valued partner for us. Galberth Health is one of our go-tos for therapy resources, dementia resources, and evaluation in the Triangle area and a little bit beyond, as Latoya and I were talking about earlier. So Latoya, I'm going to let you give us all the details of your background and how you got started in this. But I just really did want to thank you and especially thank you for sharing this topic that is really near and dear to my heart. I know that there's a lot of questions out there about how can therapy assist someone who is living with dementia, and is it really worthwhile, and how do we go about doing that, especially in this COVID day and age? So I'm going to let you go ahead and jump right in. I know you've got answers to so many questions. I did want to let people know if you have questions as we go along, please feel free to drop those in the chat, and we'll answer those as we can. So Latoya, I'm going to send it over to you.
Thank you. Good morning, everyone. And thank you so much, Lisa, for that introduction. Again, I'm Latoya Galberth, an occupational therapist by trade, as well as certified dementia practitioner, as well as rehab manager and owner of Galberth Health. And we are an in-home rehab agency that specializes in dementia care. And essentially, the inception sort of came about because we found that there was sort of a disconnect when it came to therapy services and dementia care. So we worked really hard in trying to bridge that gap and again ensure families and caregivers that again there is a place for therapy in the realm of dementia care. So again, I am truly excited to be with you all on this morning, again sharing the two things that I absolutely love and am very passionate about. Again, therapy along with dementia care. And before we dive in, and Lisa has already sort of touched on this before, for those of you who may have logged in after, I just wanted to highlight one housekeeping feature in particular, which obviously involves use of the chat box so that we can keep this segment as informational and as conversational as possible. Again, I will do my absolute best to monitor the chat box, but thankfully I have reinforcement by way of Lisa that will help orient me to any questions or comments that I may miss during or after the presentation. But again, for now, I just want you all to help me test this feature. So if you hadn't done so already, I just want each and every one of you to just take a moment and simply insert where you are from or where you're logging in from. I do want to see essentially where our reach extends to this morning. So again, please type in the city and the state because some mornings I can be a bit geographically challenged that you are tuning in from because who knows, we could make some local connections and you find that there is someone literally within miles of you that you could connect with soon after this call and hopefully further this conversation. Conversation. Awesome. And I see we've got quite a few of our North Carolinians here. So I did see a Clayton and Raleigh. I'm also trying to check a few places off of my bucket list as well, so that helps. All right, right, so I wanted to do that for two reasons. Number one being so that you can see that you are not in this alone. As we sometimes seem to think, particularly as caregivers, that we are the only ones in the world with these experiences, and there's no one miles away or even up the street that could possibly ever understand what it is that we're going through, right? Especially those of us who may be from smaller communities. I have a relative, my grandmother to be more specific, who constantly says, no one understands what I'm going through. Now, outside of me saying, hey, Grandma, I kind of work in this field, I now have written proof that she is not the only one with questions and or concerns as a caregiver of a loved one with dementia. And then the second reason is now I know that each of you have the tools and the means to comment and or ask questions about anything related to this topic. So without further ado, let's discuss the benefits of therapy and dementia care. So, although we're discussing the benefits of therapy and dementia care, I wanted to start by asking you about your experiences with rehab and therapy in general. So, just by a quick show of hands, for those of you that I can see, how many of you have had to receive any type of therapy in the past? And I'm speaking to physical therapy, occupational therapy, or speech therapy. More specifically, over the past 10 years. Okay. And how many of you have had to consent to or observe your loved one with dementia undergo one of those therapies recently? Okay, so in the chat box, again, really quickly, or you can just make a mental note or jot it down. What would you say one of the biggest differences was in terms of the therapy that you received and the therapy that your loved one with dementia received? And the biggest challenge that you may have noticed or saw for your loved one diagnosed with dementia. And or the biggest success, I guess I should say, because we all love a good success story, right? And also, I want you to think about if you or your loved one did not participate in one of those therapies and it had been offered or recommended by way of referral, what was your biggest concern or hesitation? So again, you can put this in the chat box, jot it down, make a mental note, because I do want to kind of revisit these, but a lot of those concerns and again, reservations, I will be able to address throughout the presentation. So again, just keep those in mind, even if you weren't able to answer as of yet as we go throughout this segment here. So for most of you, this isn't your first introduction to dementia, right? And you've gained quite some knowledge either through seminars, your own personal research, primary care physicians, neurologists, the Dementia Alliance of North Carolina, or other means. So I wanted to start by simply discussing therapy. And not just therapy, but therapy and dementia care. So let's just start by defining therapy. So what is therapy? If you Google this, which I did, you will get close to 1.6 billion responses. So I wanted to provide you with a broader definition and then one that speaks directly to rehabilitation or what we do. So therapy has been defined as the attempted remediation of a health problem following a medical diagnosis, and this can range from counseling to psychotherapy, immunotherapy, etc. And then there's rehabilitation, which you'll often hear condensed as rehab. And this helps a person to be as independent as possible in everyday activities and helps and enables participation in education, work, recreation, and meaningful life roles. So we're often referred to as rehab therapists because of the life application or that doing piece. But the terms are typically used interchangeably, but I wanted you to know the context and how broad or specific these terms can be, because again, there's music therapy and art therapy and animal therapy and aquatic therapy. But the three disciplines of therapy or rehab that we will be discussing today are physical therapy, occupational therapy, and speech therapy, which is also known as speech language pathology. So let's start with physical therapy. And this is probably the one that we are most familiar with, right? And this is a field that is comprised of movement experts that enhance mobility and function through prescribed exercise, hands-on care, and patient education. And then there's speech therapy, again, better known as speech language pathology. And this is a discipline that's devoted to preventing, assessing, diagnosing, and treating speech, language, communication, swallowing, and cognitive disorders. And then there's occupational therapy, the discipline in which I do have a slight bias towards as an OT, especially in the world of dementia care, because I feel that it pulls from both physical therapy and speech therapy and maximizes or truly focuses on function. So we work with clients to build and or restore their abilities to perform some of those day-to-day activities. We help patients develop, recover, improve, and maintain the skills needed for daily living. So now the question becomes, what makes each discipline effective? And the beauty and effectiveness ultimately boils down to the collaboration between all disciplines. So it's not just a multidisciplinary team that you may be encountering, but we are truly interdisciplinary, meaning that we essentially work well together and uncovering some of those difficulties or challenges within our scope of practice, and then applying that to some of the other therapies or disciplines that are also working with that individual as well. And it truly ensures that there is no stone left unturned, which can certainly be the case when we discuss dementia with its many symptoms and presentations. So it's important that we look closely at what each discipline has to offer, and again, how it could directly impact your loved one. And also note that these are not mutually exclusive, meaning you don't have to decide on just one. It doesn't have to be PT or nothing. You can have PT and OT, OT and speech, just OT. Again, just depending on what that individual needs and what some of those impairments or functional deficits are. And we're going to talk about this in just a bit. But one thing that you all have likely experienced is that dementia does not just affect memory. It does not just affect speech. It does not just affect walking. It just does not just affect dressing or feeding. The symptoms of dementia has a way of bleeding into so many areas of our day-to-day living and just one's ability to perform some of those basic tasks. A quick example is sometimes we will receive an inquiry or a referral, again, just for physical therapy, and we may ask, or I'll ask rather, not only about the physical changes or challenges, but about some of those specific end goals for the caregiver or the patient. I've had the response of, well, we just need physical therapy because I just want mom to walk again. So I do a little bit more digging and I say for the purpose of, and then I have the family or caregiver fill in the blank. So I'm really trying to get a true idea as to the why. Is there a walking club that we want mom to participate in, or is there an event or an activity that is based in walking? So again, what is the why? Because more often than not, difficulty in walking means difficulty in doing other things around the house, like getting in and out of bed or dressing. So we want to be as accurate and as thorough as possible in addressing some of those needs. And then on the other end of the spectrum, believe it or not, we run into the occasional, okay, we need help because now dad is walking too much and we can't get him to sit down. So dad's not listening to their cues or knowing areas that are safe enough to walk in the home. And depending on where dad is in terms of his dementia, he's not able to communicate or express when he's tired, which means he can walk himself to the point where his mobility is unsafe and he loses his balance. And now guess what? He's at a greater risk for fall. So again, it's not just merely about walking. And we've also noticed that the novelty tends to wear off, just like with our infants transitioning into toddlerhood. They take those first steps and we're like, oh, yay. And then it's, oh no, because now we have to start proofing the house and sectioning off areas for safety because now there is a goal or purpose in mind. Now they're actually going somewhere to do something. So we're figuring out again what it is that they're aiming to do, and again, that end goal. For some families, the goal behind walking could be to ensure that they don't have to struggle so much to do transfers or lifting their loved one in terms of transferring them in and out of the car or in and out of the bed, or so they don't have to worry about transporting a wheelchair with them everywhere that they go. Or they want to take mom or dad out for weekly lunch or dinner outings, and then also think about the OT and the speech therapy implications with that during the actual act of mealtime and feeding, and how we could potentially intervene from that perspective, or so that they can take mom to church on Sundays. And over the past couple years, I've been summoned to do a few assessments in the community and churches, specifically looking at safety and entry and exit ways, ramps, lighting, not just making sure that they are adequate and sufficient enough for our seniors, but also for our seniors with cognitive impairments. And again, all of this entails so much more than just walking, right? So keep all of that in mind, as I'm sure you have plenty of examples of daily scenarios in which you or your loved one may have struggled a bit in a particular area, and you were simply unaware of the fact that someone could help, or you were unaware of the exact help that may have been needed at that time. So now, with all of that information, I wanted to provide you guys with just a quick case study to wrap that component up. So everyone meet Donald Jones, better known as Don. He is the 79-year-old, charismatic, and fun-loving spouse of Jane. Although mostly agreeable to everything Jane proposes, she has noticed that over the past few months, he has slowed down considerably and has a more difficult time getting around the home as well as in and out of his favorite recliner. She's also noticed that he has begun to repeat stories of previous events a bit more regularly, which she doesn't mind, but now finds that he can't recall directions long enough to complete his basic self-care tasks, so his bathing, his dressing, and his grooming. He compensates well by telling jokes when he doesn't remember things that were previously asked of him. And one evening, when attempting to walk to his bedroom from his recliner, he lost his balance and fell. Luckily, there were no injuries, but Jane is concerned that things may begin to spiral and would like to find supports to keep him safe in the home. He's becoming more hesitant to go out for their weekly lunch outings, and he's just not as confident in some of those social environments as he had once been before. So I posed a few questions for you all. Should Jane be concerned? Or should she just chalk it up to dementia and wait to see if there is more of a decline? And who do you think she should consult in this instance or reach out to? Kind of a rhetorical question, I know. Notice that in this case, I didn't specify the type of dementia that Don has, because for a lot of our therapists, we are more interested in the specific symptoms that are impacting function and safety versus that specific diagnosis. We all know that these symptoms can vary in terms of severity, even within one specific type of dementia. And if you've listened to any of the other seminars hosted by the Dementia Alliance, you've probably heard that when one person is diagnosed with dementia, that one person is diagnosed with dementia. The way that it presents can be broad, and where that person is along that spectrum dictates or determines their physical, cognitive, and functional abilities. However, what I would like to highlight to ensure relevancy here are the 4 most common types of dementia that we often see when we do receive those referrals for therapy. And again, there are specific markers, I guess I should say, that are either based in movement, cognition, or behavior that helps to guide our treatment process. So let's start with Alzheimer's disease. So again, most of you are probably familiar with the fact that this is the most common form of dementia. So it's no surprise that a good majority of our patients have this specific dementia. One of the hallmark symptoms is memory loss. However, there are non-memory implications that we find just as important, such as difficulty word finding. Think about how this affects overall communication. Speech therapy can be a great asset to address some of those difficulties and train caregivers on techniques to simplify communication, but also to maximize that individual's current abilities. They can also figure out what other means of communication can be provided. Your speech therapist may implement common visual aids or images or pictures for those words that are difficult to express, or create a communication book that highlights frequent requests or common phrases or commands or responses, which can be helpful, especially if your loved one is working with several caregivers. And again, we're wanting to ensure that consistency in communication. And then also think about the importance of word finding during self-care. So you're bathing, you're dressing, you're grooming. For example, during bathing, your loved one may be trying to express his or her discomfort with the water temperature. It could be too hot, or what I find to be the case most often, too cold. Or that her undergarments are bunched up, or there's a wire from her bra that's poking into her skin, and she simply can't communicate that. So as OTs, we come in as that extra set of eyes and explore each and every area by also implementing some of those newer communication strategies in the context of bathing, dressing, toileting, etc., to make it easier for both the patient and their family member. And then visual spatial issues become a bit more prominent as well. And again, this is not just merely how well one can see or their visual acuity, but depth perception as well. The visual field is diminished, and we oftentimes can mistaken this for poor follow through or poor attention, when in actuality their visual field has been cut, sometimes drastically. So you may ask your loved one to go over and grab their sweater by the bed, or to sit in the chair by the kitchen door, and they're not able to follow through from a visual perspective. So it's not always about direction following, but the fact that they can't see the object that needs to be retrieved. Peripheral vision is limited, which means they are essentially walking around as if they had the side blinders on. So if you were to take your hands or two sheets of paper and place it right here by your eyes, just imagine if this was your visual field all day long. So when someone approaches you from the right or the left, obviously you're going to be a bit startled, but also add confusion and disorientation on top of that. Or if there's an object that's laying adjacent to you on the floor, guess what? That individual is likely to trip over it. So again, this is the beauty of having multiple disciplines or therapies involved, because PTs cannot just work on fine-tuning balance and mobility, again, to decrease the risk for falls, but can work with OTs on revamping the home environment while taking these visual deficits and impairments into consideration. And then there's difficulty with sequencing tasks, which is common. So we as OTs can get creative on how to present tasks, be it mandatory or leisure, to maximize follow through as well as understanding at that particular stage of dementia. We also train our families as well to not overhelp, because we tend to do that, or at least see that a lot in the beginning, because they truly do undermine their abilities, the abilities of their loved ones once they have this dementia diagnosis. My grandfather was recently diagnosed with dementia, and my grandmother jumped in to do everything and then burned out just that quickly. After that, or after failing to realize that there were things that my grandfather could continue to do the entire time, he may have just needed a few additional cues or supports or devices or resources to do it, but he still had the means and the capability. So I have to educate families on the progression of the disease, as well as the fact that there could be a severe or an end stage that they may encounter. And this is when it will have to be all hands on deck. But if you don't have enough in the tank to support them because you didn't reach out, and access the proper supports and people in the beginning, it's going to be that much more difficult for you as the caregiver. And also note that even towards those later stages, we can still intervene. Our speech therapist can go in and complete swallowing evaluations to ensure that a proper diet is in place so that their loved one is not at risk for choking or aspirating. And we can help order wheelchairs if and when needed to ensure proper fit. Because I can't tell you how many times an inappropriate wheelchair has been ordered without a single therapy assessment. And they're ultimately stuck with that chair for 5 years because Medicare will not pay for another one. And again, I know when it comes to wheelchairs, they all look standard and that they all serve the same function and purpose. But if it's ill fitting, it can cause major issues down the road. I'm talking of hip and knee contractures, poor or worsening posture if they don't have the proper back and lateral supports, or even skin breakdown if the cushion isn't sufficient. So they're now at a greater risk for developing decubiti ulcers or pressure wounds. So again, these are definitely all things to take into consideration before you take it upon yourself to go out and order some of that equipment without a proper assessment. So we are here to help you not only be proactive, but to get it right the first time so that you aren't stuck later towards the end trying to figure out those loose ends again later down the road. And again, the symptoms of Alzheimer's that we can address from the early to end stages are almost endless, and you'll see that it's also prominent in other types of dementia. So there are several other areas that we can address that aren't listed here, but these are just to give you all ideas and things to consider with your loved ones moving forward. So next we have vascular dementia. And this is one of the most common types for us because of its correlation with those who have had a stroke or a CVA or a TIA. You all likely know the role that therapists play in rehab for those who are recovering from a stroke. So this is no different, but obviously there is a heavier emphasis on the cognitive deficits. And this can also vary too, depending on the area in the brain that was affected by the stroke. For a lot of our patients, thought formation, attention, and executive functioning are severely impacted. And this controls not just what you do, but how you do it. And this is where, as OTs, our task analysis comes into play so we can decide what those specific breakdowns are and what strategies or even devices that we can employ or implement to make that task easier or at least more manageable. For example, do we need to simplify a remote control? If it's anything like my remote control at home, it has a gazillion buttons, and I'm only interested in changing the channel and adjusting the volume. So for someone, again, in those earlier stages who are needing that simplification as well, again, we can enter to make, again, some of those quick fixes or modifications so that they can enjoy just the act of being able to watch television independently. Or looking into our home automated systems. For instances, our ability to control the lights. If you or a loved one are having difficulty remembering to turn on or turn off the lights after a certain event, or with any of the other appliances that you may deal with on a daily basis, this can certainly be an alternative to resort to in that instance as well. The Amazon Alexa or the Google Home are becoming a bit more popular too, even as it relates to medication management. Again, for someone in those earlier stages who are needing simply auditory cues or auditory reminders to be able to perform some of those tasks a bit more successfully and accurately. Speech therapists can help us problem solve when and where to add in breaks to reduce frustration when attention wanes and figure out ways in which we can compensate for that. Maybe going through photo albums of familiar faces of families and friends to increase focus or even help with redirection. I found that sometimes this is more effective than having your loved one sit down and watch reruns of the Andy Griffith Show. So it definitely varies. And we also know that if the TIA occurred in the area of the brain responsible for movement and coordination, which is the cerebellum, then having PT and OT involved for safety and gait training is essential. Again, it becomes a matter of safety and independence, and those elements will always be what we strive for. If the damage from the TIA or the CVA is irreversible, and it is unlikely that this individual will return to their baseline, which again is what we want and what we strive hard to accomplish, again, having them return to that baseline. Then we provide the patient and the caregiver with the necessary equipment, education, and modifications that are needed to, again, adjust to that new baseline for that individual. Now, it's very important to note that early intervention for someone who has experienced a CVA is key. Research has actually shown that recovery in various abilities is much higher when we don't delay treatment or therapy involvement. And then another thing to note is that with dementia in general, there is a time frame in which new assistive devices can and should be introduced to ensure safety and carryover. And I'll refer back actually to Alzheimer's for this example, because there are certain stages in which, again, the introduction of what we call assistive devices, so your walkers, your rollators, your canes, are optimal. And then there are times and stages in which it serves as more of a safety hazard or a fall risk. So you don't want to introduce a walker to someone in their moderate to late stage of Alzheimer's, as they will not retain that information needed and do so on a consistent basis and or use it safely, and they'll likely leave it around the home or the senior community or ignore it altogether, particularly if they've never had to use one at all in their lifetime. I've had patients who were previously prescribed the walker of their spouse, and we would do a bit of training, and they'd take maybe one or two steps, and then they'd place it nice and firmly in front of them and then simply walk around it. So this would only be introduced in those later stages if you or the caregiver can provide them with complete supervision and assistance to ensure safety. In our earlier to moderate stages of dementia, we do have the ability to use visual aids or visual prompts, as well as intensive training to ensure that comfort and convenience and routine. But again, as it progresses, compliance becomes much more difficult, which is why I urge families to at least consider a therapy assessment sooner rather than later. Now, does any of your loved ones do any furniture walking? And when I say furniture walking, imagine that they're in the middle of the living room and they need to get from point A to point B. So they're grabbing hold of the back of the sofa and then the back of the recliner and then the coffee table and then the wall. Looks okay? Maybe for the time being, but not really. So while they're cognitively capable of realizing that a support is needed, this is where we come in again to make modifications within the home and again provide some of those alternatives, because the longer we allow this to go on, the higher their risk for falls. And then another area that OTs address that can be common with vascular dementia as well as others is incontinence. And we typically divide this into two categories, with the first being functional incontinence. And this incontinence is due to the person's inability to make it to the bathroom in time. And this can again be related to mobility. Say their bedroom is on one end of the hall and the bathroom is on the completely opposite end. And from a mobility standpoint, they simply can't make it to the bathroom in time. This could also be due to balance impairment. So I've been in quite a few bathrooms and I found that there are not always the proper supports in place, especially for someone who may have a difficult time transferring onto and off of the commode. So again, this can certainly increase that person's incontinence episodes as well. And then clothing management. So let's say, for instance, they are able to make it to their bathroom in time and they do have balance that's sufficient enough to transfer on and off of the commode, but they don't have the strength or dexterity to unfasten their belt or manipulate their zipper or pull down their pants. So these are areas too that we as OTs come in and assess and can address through therapeutic intervention. And then there's your typical urinary or bowel incontinence, where by the time you realize or that you have the urge to go, you've already gone. So we work with families to put together a bowel bladder program. And for those in their earlier stages of dementia that can participate in Kegel exercises to strengthen those pelvic floor muscles, we focus on that. One of our OTs is actually credentialed and certified in the area of pelvic floor muscle strengthening. So keep those things in mind too when you're looking for therapists or clinicians with certain designations or specializations. And then we help figure out the contextual challenges or changes that are needed to improve mobility to the bathroom and or ways to, again, increase a simple toilet transfer for a loved one who may be having difficulty in that area. The most important thing to note is what can happen if we don't address this issue of incontinence, such as your UTIs, so your urinary tract infections, and how in some instances this can actually worsen those symptoms of dementia. So our goal in this instance is to control, address, and treat this as much as we possibly can. And then next, I wanted to move on to Lewy body dementia. So one of the key markers here in terms of what sets it apart for us as clinicians or therapists, outside of thinking and the memory component, is how closely it's related to Parkinson's disease. For those of you who may not know someone with this diagnosis, there are protein deposits that are labeled Lewy bodies that are deposited in the brain and the nerve cells that are responsible for thinking, memory, and movement or motor control. And this often shows itself as muscle rigidity or muscle stiffness, slowed or shuffled gait. So you may notice your loved one shuffling a bit when they walk, and or tremors. So of course, as OTs and PTs immediately think of how this increases one risk for falls. So again, gait and balance training are essential, and making modifications within the home for safety. As OTs, we have access to a lot of equipment that can help manage that lack of coordination, particularly that lack of coordination associated with tremors, such as your adaptive utensils that are most useful, obviously, during mealtime. So having a bigger base or a handle for manipulation. And then we're also looking at ways to facilitate improved posture during mealtime or during any other task that may require a tabletop or for that individual to maintain that upright position. And then again, our forte and expertise also lies again in administering the most appropriate walker or other assistive device, and then training caregivers on how to cue their loved ones to implement some of those big movements. Again, that are commonly associated with those who have been diagnosed with Parkinson's as well. Incorporating these visual aids if needed. If the person forgets to initiate some of those bigger steps, we typically cue on the 4 S's. If you start to notice your loved one with that shuffle gait, having them stop, stand tall, shift their weight, and then start again. And then again, communication is also huge here, as we also see, again, a common shared symptom with Parkinson's of slowed speech and soft speech, in which speech therapists can work on vocal production or vocal amplification and do training with caregivers, particularly in the earlier stages of the diagnosis. And then it's also important to note that motor performance or motor movement isn't just confined to those larger movements, but oral motor function as well, which is obviously your motor function relating to the mouth. And this can also trickle down to one's difficulty in swallowing certain foods. And you may again begin to notice a bit of pocketing. So instead of having that food once ingested following that traditional path down the trachea, now it's just sitting in your loved one's cheek. And if they're not able to clear appropriately and swallow, obviously, they're at an increased risk for choking and or aspirating with certain food items. So an early consult with a speech therapist will ensure that the proper technique, along with a diet that coincides with their cognitive ability, is in place as well. And then lastly, we'll touch on FTD, so your frontal temporal dementia. With this type of dementia, the frontal and temporal lobes of the brain are primarily affected, which prompts impulsivity, poor reasoning and rationale, impaired communication, and of course, our behaviors. And again, these are the major markers that we see when it comes to referrals and our involvement, which again doesn't mean you're not going to also see limitations with movement and memory or communication. We usually see this diagnosis on a referral sheet that reads in all caps and sometimes underlined, safety. So with this diagnosis, there are two variants, if you will, one that's based in behavior and the other in PPA, which is your primary progressive aphasia. So I'm definitely going to get into the behavior piece a bit more, but I definitely wanted to point out the aphasia, which is that person's inability to understand or express speech. And just in case this definition didn't give it away, this is when we would have speech therapy involved. So the implementation of compensatory strategies through word finding and communication techniques will be focal points, as well as focusing on ways to maximize their current communication skills. And this can again be either through communication devices or communication boards. Now, as it relates to behaviors, obviously one can conclude that their inability to communicate effectively along with other cognitive deficits can and will greatly impact their behavior, which again is already a target area with this type of dementia. So that person's inability to control or regulate their emotions or behaviors obviously puts them at an even greater risk for safety issues. Whether it's elopement, loved ones trying to leave home or their senior community, or being of danger to themselves or others, or extreme agitation or combativeness, which again can also be prevalent in other types of dementia. This is where our interventions are typically focused. And this is also where I see OT as being one of the most effective because our holistic lens or background allows us to hone in on some of those cognitive and communication issues, as well as ways in which we can alter their context and supports to keep them safe, obviously. And not only can we go in and modify the environment, but add a bit of organization and structure to what may seem to be chaotic for your loved one to help mitigate some of those behaviors. And sometimes this is a matter of finding those tasks that are appropriate from both a communication and a cognitive standpoint so that that individual does not become more frustrated again, which can lead to some of that agitation. So we'll help identify tasks that aren't engaging enough or that may be too stimulating so that we can ensure that just right fit and also ensure that they're not in search of something else to do, which, especially if it's unsafe, we want to make sure is a deterrent for them. And then we also need to have the basic understanding outside of the specific dementia diagnosis that some behaviors are simply a response of relieving fear, relieving anxiety, pain, stress, or an unmet need. Remember when I discussed self-care and communication earlier, using the example of the bra wire that was poking into one's skin. OTs and speech therapists are here to figure out what those culprits are and what those messages are due to that person's inability to communicate. Again, so that we can lessen some of those negative responses or behaviors and go in and make some of those necessary changes. So this can entail creating distractions and or techniques to redirect, and then introducing or implementing more healthy routines that again will lessen that burden for families or other caregivers. And this is the perfect segue into something that I feel each therapy discipline can and should contribute to, and that's caregiver training. This is the glue. I received a call earlier this morning, in fact, from a caregiver who said that mom is in her upper 80s, she's taking care of dad, and she's just no longer sure of what to do, how to do it, or what lies ahead. And she's been his primary caregiver for roughly 3 years. So can you imagine being in that role for that length of time and still not understanding ways to manage your loved one's dementia? And more importantly, the people or the resources that are in place to help you do it. So many of you can probably relate to that scenario. I love doing caregiver education and training within the context of the home because I get to see firsthand what is happening. Or sometimes what's even more important, what is not happening. It could just be an oversight or a misunderstanding that causes a complete breakdown with communication, self-care, mobility, behaviors, etc., that a clinician or a therapist can come into the home and attempt to remedy. And this is usually where our assessments originate and is definitely the crux of what we do because we want to ensure that when we discharge that you are more than equipped to handle some of those day-to-day tasks with a bit more ease and confidence in your own abilities. And that starts right here, literally right here, your connection with the Dementia Alliance and even your participation in this presentation this morning. And to simplify this even more while providing a bit of a wrap up on everything we've discussed, I have this analogy or this spinoff that I like to use. For those of you who are smartphone savvy or still learning the ropes, which I can honestly say that I am, you know that there's an application or an app for just about everything, right? You need to know tomorrow's weather. There's an app for that. You need directions to your favorite restaurant. There's an app for that. You need to order something online from Target. There's an app for that. You need to know what your toddler ate this morning at daycare, which is applicable to me at this moment. There is an app for that. So I decided to keep that theme going with there's a therapist for that. So your loved one can't transfer out of their recliner or bed. There's a therapist for that. Your loved one is having more difficulty with word finding. There's a therapist for that. Your loved one is refusing to bathe and is becoming more agitated. There's a therapist for that. Your loved one is becoming more unsteady on his or her feet or has had a recent fall. Your loved one has moved home or into a community and is more confused or needs help reacclimating. There's a therapist for that. Your loved one has shown a great decline in their ability to complete bathing, dressing, and grooming. There's a therapist for that. Your loved one wants to remain at home, but is having more difficulty with structure and organization. There's a therapist for that. There are certain parts of your home that you think are unsafe or may cause fall hazards. There's a therapist for that. Or your loved one has experienced a significant decline since COVID and they can no longer participate in the community or socially as they had before. There's a therapist for that. So now the disclaimer is that because there's a therapist for that, it doesn't mean that this issue will be resolved quickly and without challenge. But we are fortunate enough, however, in that we've been able to make some pretty impactful changes in the lives of both our seniors and caregivers, even if we have to change the course of our treatment or the direction when we're doing that. So most don't think, again, that therapy and dementia care go hand in hand, but hopefully now you see that there is not only overlap, but great benefit in making this a part of your care plan and therapist a part of your care team, or as I like to say, a part of your village. So I just wanted to reiterate here that there is so much potential and so many benefits of therapy and dementia care. We are obviously not in place to stop the disease, but to give you and your loved one the resources needed to manage it. We often see families that have allowed dementia to essentially run their lives instead of being proactive by reaching out to clinicians or therapists such as ourselves to take charge and manage that disease process. This is so important for all parties involved. If these times haven't shown us anything, it's that living is so important and that our physical and cognitive health go hand in hand. And more importantly, you don't have to do this alone, like ever. So any notion or misconception that therapy interventions won't help because the disease is progressive is completely false. We all know that we're going to age. I'm not the same person that I was 5, 10, 15 years ago physically. And I know 20, 30, 40 years from now, I probably won't be as well physically or cognitively. But do we sit back and just wait for the inevitable, or do we maximize our time and our abilities later in life in the same manner in which we would today? So I'm not trying to become a motivational speaker here, but as one of my patients would always say, we can always do something. So ladies and gentlemen, I have introduced to you your 3 somethings: physical therapy, occupational therapy, and speech therapy. So now I'm going to stop talking and open it up for questions because I see we have maybe just a little under 10 minutes left. But in the event that I can't get to everything, I did provide just a brief context to help alleviate some of the stress or questions that Lisa may receive as well.
Thank you so much, Latoya. This is
Absolutely.
I'm laughing because I so agree with you on all of this. There's a therapist for that. So with COVID and with concerns about having people come into our homes, if we, first of all, where do we start? Do we call our primary care provider first Do we just call a therapist? Who do we call? And then if we're concerned about having an OT, a PT, an ST, everybody coming in, is there one person that we should target our search to, or how should we go about looking at that?
So essentially, in the beginning, and I know we're geographically kind of spread all over the place, so it will vary in terms of whether or not a therapist or a clinician or the primary care provider should initially receive that first consultation. But I know here in the state of North Carolina, if I were to receive an inquiry or a phone call from a family who needs therapy services, I could go in and initiate that assessment as long as the primary care provider is able to sign off on that assessment within 30 days. Now, typically, what a lot of therapists like to do, again, we want to cross all T's and dot all I's, is to have that primary care physician or that neurologist involved from the very beginning. And this is just a part of us informing the care team at large of what we're doing, what our goals and interventions will be, and the duration that essentially will take place. So I always encourage families to just do a little bit of perusing to see what options you do have available to you in terms of some of those resources, particularly in the home, and then reach out to your physician. It'll help expedite the process if they can go ahead and sign off on that order in the beginning. But in most instances, whether or not you contact your PCP or the therapist first, the end result will be the same. It's just a matter of how quickly you're able to get that person inside. Now, obviously, again, I'm a bit biased as an OT, so I would always say I confer with your OT initially. Like I said, the beauty with our discipline or in our discipline is that we are able to tackle both those physical and those cognitive needs. And because everything that we do is contextual based and we're able to kind of go in and make a few modifications in the home and again, just tweaks here and there on recommendations and assistive devices, usually having us as that entry point can help address some of those needs while you're also in the process of waiting for physical therapy and speech therapy to come in. So it also kind of eliminates a lot of that foot traffic. If you are concerned about having too many bodies in the home at once and you want to just take those extra steps to be cautious, but either discipline, again, you can't go wrong. Like I said, we are an interdisciplinary team. So if the PT goes in initially and they see that there is a decline in bathing, dressing, grooming, or a need for a more in-depth home assessment, then they should also reach out to their colleague that's an OT as well to come in and complete their part of the assessment as well.
Great, thank you so much for that. Who, what type of primary care doctor do you receive most of your referrals from? Would it, I mean, would it be a primary care? Would it be I'm speaking regarding dementia. Would
Yes.
it be a neurologist more often? Who do you tend to get more referrals from?
Honestly, it varies. And I will say too, it also depends on the time frame or the time that has elapsed since that person has seen a provider or a clinician. So if they haven't seen their neurologist in over a year, more often than not, I will receive the referral from their primary care physician who is aware of their dementia diagnosis, but feels a bit more comfortable and authorizing or consenting to therapy more so than the neurologist. But if they are essentially taking turns and they're seeing their neurologist on a pretty regular basis as well, then we can move forward with the referral from that particular provider as well. So it varies. It's just a matter of who the family or that particular senior is most comfortable with in terms of, again, granting that consent for therapy services.
Great, thank you.
Yeah.
Okay, so let's talk a little about finances. You know,
Yes.
everything in this day and age costs something. So, how do we pay for these services? How do we pay for that initial consult and then for follow-up kind of consults? Is that insurance? Is that um, yeah, Medicare, Medicaid? How do we pay for that?
Yes. So in terms of our primary payer source for reimbursement, it is usually through Medicare. So those that are Medicare beneficiaries would obviously qualify and have the majority of their cost written off. Now we are, and I guess I should kind of have this as a disclaimer as well. We operate as an outpatient provider that's able to service our seniors in the home. So there are other therapists or providers that are essentially home health that also require, or I guess I should say, accept Medicare in terms of the payer source, but they bill a different part of Medicare. So essentially for us, it would be the exact same as if you were to take mom or dad to an outpatient clinic. In terms of trying to decide whether or not there's co-insurance or a copay, if there are certain stipulations in terms of how many visits are going to be granted. So there is a little bit of red tape there, but typically it would equate to the same cost or coverage that you would essentially encounter if you were to take mom or dad to their PCP. So Medicare, any other third party payer source, be it Blue Cross Blue Shield, Humana, United Healthcare, and then obviously the option for private pay as well. I will say, because I think I also saw this question that was sent to you prior to the presentation, that there is an end game or a cap. Medicare and other payer sources will not pay or reimburse for therapy services indefinitely. So there is the option for private pay if families want to extend some of those sessions or therapeutic interventions well beyond the point where their loved one has reached the majority of their goals and begin to plateau. Again, we are in place to provide services that are skilled and medically necessary. So when it gets to a point where things start to plateau and it becomes a bit more of maintenance, and these essentially exercises can be completed by a caregiver or an aide or a family member, then we'll have to discharge. But again, it doesn't mean that later down the road, once things start to change a little bit and their dementia progresses, perhaps that we can't re-intervene. But again, in the event that you just can't let your therapist go, and insurance or Medicare is saying, okay, we've given you guys ample time, there's the option for out-of-pocket pay as well.
Thank you. As with most services, it's complicated, but it's really not.
Yes.
and for those of us that work with people with dementia all day long, we know that therapy is definitely necessary. And quick, a question, I guess, for me would be at the point where maybe you are no longer going into the home and working with the person who's living with dementia, would you be open to doing phone calls, Zoom, telemedicine, something to follow up with that caregiver so that they can feel confident in the skills that they're practicing and what they're doing? For example, the person that talked to you this morning, after they
Yes.
get all of those services and everything lined up, are there therapists out there that are willing to continue those paid conversations to make sure the skills remain with the caregiver as well?
Yes, absolutely. And again, we are certainly in unique times, so we've had to kind of switch gears in our platforms a little bit, just to make sure that we're continuing to address some of those needs, not just from the senior standpoint, but from, again, the caregiver and the family standpoint as well. So even after those assessments, even during sort of the earlier part of the pandemic, when families were just strictly opposed to just having someone enter the home, which we definitely understand and respect. We did offer the option, and Medicare and other payer sources sort of got on board as well in terms of providing reimbursement for services that were delivered through a virtual platform. So there's definitely the option for at least continuing therapy services in that realm. Ideally, and it definitely depends on the case, in terms of whether or not are more physical limitations or challenges that truly require hands-on care. We do like to at least initiate an in-person assessment, again, so we can kind of get a true sense for where they are physically and functionally, mobility transfer wise. But once those parameters have sort of been in place, then we can follow up again virtually or via phone calls with family just to ensure that safety is not being compromised. And again, that consistency is continuing to be there for all parties as well.
Well, we unfortunately have reached our time limit, and I know there's more questions out there to be asked. So everyone does have your contact information. We will be sharing slides and the recording information of this with everyone who registered. Again, we so thank you, Latoya, and all the therapists at Galberth Health for bringing this information to us and being so open and so accessible to answer our questions. Thank you to everyone who joined us today. We again want to thank our sponsors, ESI and Aware Senior Care. And if anybody wants to email me directly questions for Latoya, we're also happy to share that information with you as well. So Latoya, thank you for sharing your expertise, for being our
My
expert
pleasure.
today on Ask the Experts. Thank you all for joining us. Be safe and be well. Thank you.
Thank you.